delighted to have with us Dr. Lisa Allgood, who is not just the Executive Presbyter of Cincinnati Presbytery, but she holds a doctorate in immunocytochemistry. Is that right?
That's right. Well done.
And worked for 36 years in the pharmaceutical industry at Merck and Procter & Gamble and MedPace as an executive and researcher. And she has been the PCUSA go-to guru on viruses, variants, and vaccines throughout the pandemic. So welcome, Lisa. We have also on our call someone who is not officially part of our panel, but is someone who is known and appreciated for his expertise, and that is John Baker. Is John on our call right now, or has he not been able to join us yet? We may be joined by John.
I think so, but are you recording, Dan?
I think we're recording. Yes,
I
we're
hit it, but I
recording.
wasn't sure if that working.
Yep, we're recording. John is the director for labs at Sparrow Health Systems in Lansing, and he is also a CRE, Commission Ruling Elder at Rosebush, and he has been part of the public information resource for Hillsdale Hospital. So when John does join us and if he has something to share, we will certainly welcome his input as well. Let us begin with a word of prayer. Gracious and loving God, you are sovereign over this world. You made it, including ourselves and even the viruses that we see emerge and mutate. They do not exist except by your providence. And so, oh God, as we are tested in this time with public health issues, with concerns for our churches, the safety and health of our members, as well as the vitality of our ministries, we ask that you would give us all hearts and minds and ears that are open to what we need to hear to be your faithful disciples, especially in this time and circumstance. We thank you for Lisa, her willingness to be with us, and for the wisdom she will share with us. Be with us during this time together, we pray in Christ's name. Amen.
Amen.
So Lisa, welcome. We're so glad to have you with us. And I'm just going to give you a applause and invite others to join in welcoming you. We're just going to delve right in, if that's okay. And I'm going to put you on spotlight, if we can do that. Spotlight for everyone. There you go. So everyone can see you. Can you help us to understand where we stand now in relationship to the coronavirus and the pandemic, and how has the Delta variant changed the nature of this, of our response in the pandemic itself?
Yeah, I mean, if you remember back last year when we talked originally, the variants emerge as a natural consequence of the way the virus replicates in the body. So every time the virus replicates, it actually replicates incompletely. These are not well-engineered particles. I can't even call them alive. And so that's how the variants emerge. They literally evolve on a second-by-second basis. The vast majority of those variants are not viable, and so they disappear from circulation, but those few that are more infectious opportunistically become more prevalent in the circulation. And that happened originally with the Alpha variant that came out of the UK, the Beta variant that came out of South Africa, and now we've got the Delta variant, and there are some that are emerging after this. So the Delta variant, unfortunately, as insidious as the original virus was, with a minimum infection time of 15 minutes, the Delta variant is 200 times more infectious than the original virus. And so if you do the math on that, it's about 1,000 extra particles for every one of the original particle, which means, take the math all the way down, the minimum infectious time for the Delta variant is about 10 seconds. So it's just rampaging through primarily the unvaccinated among us. And so there are two things at play here in terms of where we are. And I actually did look up Michigan numbers. You guys are doing pretty well right now in Huron Presbytery. You've got a couple of counties that are in the middle, but you really actually right now are fairly low. So incidence is high, but your infectivity rate and your ICU utilization is actually in really good shape. So keep it up. But the two things that are going on is that we've got a highly infectious, highly disease-laden virus that is going through a population where in the United States, we have about, on average, 54% of the population is fully vaccinated. So the longer that we keep an unvaccinated population running around, the more variants will emerge, and the more we end up with just continual spread of COVID. There have been breakthrough cases of Delta, and I think certainly in my circle, there have been a couple that have become serious, but for the most part, breakthrough cases in the vaccinated are either asymptomatic or come across as a small cold. Vaccinated people can still shed virus and still be infectious. That's why CDC went back and said even vaccinated people should be masked at this point if you're in an indoor gathering or an outdoor large gathering with a lot of people that you don't live with. It's also, but they shed less virus. And so the vaccines are really working there. The breakthrough rate for vaccinated people is about 5%, but the hospitalization and the death rate is 99% unvaccinated people at this point. There have been some recent studies, one that came out in September, published in a peer-reviewed journal, The Lancet, that talked about how well the vaccines are working. It basically said that of the 1.2 million adults that were studied between first dose, less than 0.5% reported getting any breakthrough. And among people who got 2 shots, fewer than 0.2% experienced a breakthrough. So the vaccines are very, very effective. They're also, as we've said before, very safe. The mRNA vaccines and the J&J vaccine have gone through decades of testing before we actually got to this virus. So the platform of the vaccine is well understood. The safety data is well established. This is just the first time for the mRNA vaccines that literally we've gotten one that also works. So that's really
mRNA refers to the Pfizer and the Moderna vaccine.
Pfizer and Moderna, the messenger
and
RNA
J&J is
platform.
Johnson & Johnson, right?
Correct. The other study that came out from the CDC back in September was that masks work. They went back to flu rates in 2019 and 2020. Of course, the flu in 2019, we were not masked, but the flu season in 2020, we were. And so what they showed was the incidence of flu cases in 2020 was 91% lower than it was the year before. And that in hospitalizations, we had about 1% nationally of hospitalizations for flu in 2020 versus years before. So masks work as well. And the most recent, of course, is that Merck, which is actually the first company I worked for, has developed an antiviral product that worked so well in clinical trials that they actually stopped the clinical trial and put together an application to FDA. It's, this one's hard for me to say, molnupiravir. It's an antiviral. It is not a replacement for the vaccine, so it's not like a vitamin, but what it did do was it cut hospitalizations and deaths by 50% in infected individuals. So it's a very, it's a much easier way to manage those people who become significantly ill and need to be hospitalized. So that's all the good news.
And so that is kind of like, what was it, remdesivir? Is that the one that they had been using the monoclonal antibody treatment?
Remdesivir is an antiviral. The monoclonal is a different kind of treatment, but both of those have shown to have some activity in treating the disease. The antibody monoclonal is slightly better than remdesivir. Molnupiravir is a variant on remdesivir. So it's one that is engineered a little bit more specifically for COVID. The same idea, same idea. And the other good piece of news, I think this is also national now, is that we're beginning to see, I think, the end of the peak. Now, let me remind you, we've been here before. We've seen peaks that come and go. As we've gathered now 18 months of experience with this virus, it looks as if the peaks have about a 2-month shelf life, if you will. Nobody really knows why, but it looks as if the peaks peak at some point, stay around for 2 months, and then start to decline again. You can't really attribute it to anything except people getting cautious again, which is good, masking and doing social distancing and avoiding large crowds. In this case, it has also, because of the extreme nature of the disease that Delta has caused and the extreme infectiousness of it, it has also caused a little bit more of vaccinations. So people are a little bit more prone to get a vaccine, but we are still nationally only 54% vaccinated. And that's not a great thing at this point. Even countries that are 70, 80% vaccinated are seeing some breakthrough, but they're seeing very little, and they are not dealing with Delta quite the way we are. Deaths from coronavirus jumped 131% due to Delta over the period from July to September. The really important part here to know is that Delta has been hitting children, and partly because they can't get vaccinated, but also the younger population that is refusing vaccines much, much more hard this time. So there's been a 500% increase in hospitalizations in ages 5 to 25 between the time of August and September. And so those are the kinds of things that have been overwhelming the hospital systems. I know here in Ohio, we have a ton of major hospitals in Cincinnati, but our ICU was actually at peak at one point, and they were beginning to invoke crisis operations so that people who were doing elective surgeries, things like that, were being turned away. And that's really, really scary. The same is true also of the emergency rooms. The emergency rooms were turning away anything that was not COVID. So even if you were having a serious heart attack or something like that, unless you were really in the throes of it, they would try and take you to a clinic of some kind. And that's really, really scary.
So speaking of vaccines, we've heard a lot recently about vaccines for children and youth.
Mm-hmm.
And, I know that I think Pfizer's been approved for 5 through 11, right?
Yes.
And at least for emergency use. And I want to be careful about that language, and maybe you can help us understand the difference between that and, a full authorization, full approval.
Yep.
And then also about boosters. I know some of us, including myself, now have reached the point where we would be booster eligible. So help us understand about the status of the vaccines, especially boosters for those who are eligible and for youth and children.
Yeah, so for youth and children, Pfizer's data is still under review, but it will be approved. I've seen the clinical data. They actually, what they have to do is titrate the dose because these are smaller humans. And so the efficacy in the 5 to 11 clinical in Pfizer was actually better than it was in adults, which is really, really good news. So that will be approved under emergency use authorization. Emergency use authorization only means that the full clinical trial has been done. So there tens of thousands of children have been studied. But what they haven't done is they've not had long-term safety data. So what the FDA does in an epidemiologic crisis like COVID, they will look at the existing data from the clinical trial as it stood and make a determination that it's safe for emergency use. And what they will then do, and they do this with every drug anyway, they will require continued safety data gathering as the vaccines are administered, so that they can build up the database. And that is what then turns the emergency use authorization to a full approval. So it goes through a second review with additional safety data. But at this point, knowing that Pfizer as an mRNA vaccine, we have so much other safety data on the platform of the mRNA vaccine itself. With this kind of high efficacy in an epidemiologic crisis, the risk-benefit trade-off is such that you say it's safe for the period that we've studied and will continue to study, and it's highly efficacious, and it's going to save lives. And that's the determination that FDA makes for emergency use. It's commonly used when there is I'm trying to think of another example. The best one I can come up with hasn't happened, and please God, I hope it never does. But if we were to, for example, be attacked by a biologic agent, and there are drugs available, those would be released under emergency use as well. And in fact, that's exactly what we are being attacked with, which is a biologic agent at this point. It's just not launched through a missile. It's launched in the air. So emergency use authorization is a full approval. It's an approval with an abbreviated data set, but it's an approval based on the entire clinical study. And I know that makes it a little confusing, but trust me, it's still a good thing.
If I were a parent or a director of Christian education, what concerns would I have about advising, or having my child or advising parents to have their children vaccinated?
And this is where I give you a biased answer that probably won't help you. If it were my child, they'd be first in line. This is such an insidious disease-causing virus. Like I've said before, it's not highly fatal, although it can be fatal in children who have an underlying medical condition. But at this point, because of the long haul symptoms that continue to be identified and continue for 18 months in people who got the early version of the COVID, this is not something I would not test it in my child. So I would absolutely be the first in line for the vaccine. The vaccine is safe. And like I said, I've seen the data. It is incredibly efficacious. It's about 97% efficacious. And so you want your children protected. I know one of my most recent love notes probably got a little pointed, but I think I said—
By the way, love notes means that that's what you call your encyclicals to your congregations about COVID. There's no worry here about anything.
No, yeah, there's no boundary crossing here. I call them love notes because it's all about science and what to do with your congregations and your sessions. So the last one, I think I said something along the lines of, if you don't believe vaccines work in children, go to your local cemetery and count the number of children's headstones before 1950, and then look to see how few there are since then. We have essentially eradicated almost every childhood disease in the United States through vaccination. We are not going to eradicate COVID through vaccination. This is an endemic virus, like the flu. It's not going to go away. It's going to continue to evolve and create variants. We will probably be getting vaccinated for COVID for years to come. I expect, and I've said this from the very beginning, I expect this to be an annual shot for a while. And so I would absolutely get my children vaccinated.
So speaking of, annual shots, tell us about boosters and what that means and who should have them and what we should be doing.
Yeah. So if you remember again at the very beginning of the COVID outbreak, as we were looking at the antibodies that were naturally generated when someone was infected with COVID, that antibody protection was very feeble. It didn't last very long. As a matter of fact, I think there was something only like 13% of the people who had been infected with COVID had detectable antibodies 12 weeks after they were done with the disease. So the natural immune response is not great. There's also two types of immune systems. There is the antibody that circulates in the blood, and then there are the cells that create the antibody. And there's the cellular mechanism for immunity is very difficult and very expensive to test for. So the antibody level in your blood becomes the surrogate. Naturally, when you're not being challenged with exposure to a virus, the antibody levels in your blood will go down. So it's not unexpected that would happen. It's also not unexpected that with viruses that mutate the way that COVID does, that the vaccines are going to wear off after a period of time. Not all vaccines do that. The ones that you get for measles and rubella, those are one and done. You're done after the first shot and boosters. But once you've gotten to a going immune system where your cellular immunity really recognizes that virus the minute it comes into your system, that's the kind of immunity you're trying to get to. And that's what requires boosters. So the mRNA got to 95, the Pfizer and Moderna vaccines got to 95% efficacy after 2 doses. And now what they're seeing is that it starts after about 6 to 9 months, it starts to wane back down. So it gets down to about 80%, which is fine. It's still very high. But they've also done clinical trials to say that a 3rd shot brings it right back up to 95. And while we've got an active, highly infectious variant circulating and a low vaccination rate from a population standpoint, you want to make sure that those people who are vaccinated are as vaccinated as they can possibly be, that they've got both the cellular and the antibody immune systems fully primed to make sure that any exposure, because it's still out in the population, can be immediately mitigated. And so that's why you would get a booster at this point. I am eligible for the booster for other reasons. I haven't quite hit 65 yet, but it's coming. So I'm actually already signed up to get my booster next week.
So you're eligible for a booster if you're in an eligible category after 6 months. And I know that I've heard that optimal timing is 8 months, but should we wait for 8 months or do you get it now?
You can get it now. And by the way, stick out one arm for flu shot and the other arm for COVID. You can get them at the same time, and you do not want the flu this year either, because since the flu didn't circulate last year, we do not have any natural immunity to any flu. You want to get a vaccine. The FDA has an objective non-FDA member advisory committee for any deliberation on a drug approval. And so when Pfizer brought the booster data before FDA, it went to that advisory committee. That advisory committee is made up of experts across the range of scientific areas that need to be in place to look at a clinical study, everything from statistics to pharmacology to manufacturing to medicine to immunology. And there's always a community representative, a patient representative there as well. When the Pfizer booster went to FDA for deliberation, they looked at it and said, here are the 3 categories we believe should get a booster immediately. And they will go back and look at it on a more broad population basis at another time. But in an emergency area, here are the 3 populations that we believe need to have it immediately. And we believe that the optimal timing is 8 months. And that was based on the data that Pfizer had. CDC came back, which is an independent deliberative scientific body, and said, we actually disagree. We believe, based on Pfizer's data, that you can get the booster anytime between 6 to 8 months as optimal. And so that's where that discrepancy comes from. CDC also said, we defer to FDA, but we believe everybody should have a booster at this point. So they sort of disagreed with the advisory committee. The FDA is not required to follow the guidance of the advisory committee, but they mostly do. And so they did in this case as well. But they will go back and look at Pfizer's data for a broader population.
Good. Now, one of our participants has posted in chat saying that I understand that boosters are only available for those that receive the Pfizer original. What about those who received Moderna? What are the options and timeline for a compatible Moderna vaccine booster?
So Moderna has their data in front of FDA now. That booster will come. I'm not going to give you medical advice or scientific advice in this case, but I have been told that if you go to a Kroger Little Clinic or CVS or whatever and tell them that you're eligible, they will give you the Pfizer booster regardless of what you've had. Not all of them check. And so I'd be really careful with that. There have been studies that came out of Israel and out of the UK that says there's no danger in mixing them. So there's no danger in mixing Pfizer and Moderna. J&J is a different subject, however. I know J&J is also testing a booster. I have not seen that data. I know it's not yet ready to go to FDA. That's the only one I would say I wouldn't mix them at this point. But there are data out there that say Moderna and Pfizer are essentially interchangeable. So Moderna
there is mix and match data that's coming. I know that.
Yes. Yeah, and actually Israel at one point had a policy where they were deliberately mixing the second dose because they felt there was some data there that said the protein, the way the protein is coded for the 2 of them to have the body recognize the protein spike on the virus, that it actually gave a better immune response, a more full immune response. So it's likely very safe. I would ask your doctor and provider if you're concerned.
All right, thank you. By the way, if people have questions, you can post them in the chat function. We will have an opportunity for you to raise your hand and be recognized at some point when we're done with the original presentation here. Let's talk about churches. That's what we're here about, our congregations and their safety. How should churches respond to the current situation? And does it make a difference if, for example, we know that most or all of our members are vaccinated? What about masking and distancing, singing, worship length, fellowship events? What about church, school, and youth events? And if other public venues are not requiring masks, why should we?
Isn't that annoying? I think, honestly, it's an individual church decision because the contexts are all so different. I have little tiny churches out at the edge of Appalachia that have sanctuaries big enough where they can very safely socially distance their 8 people because that's all they've got. I have huge churches in the urban core who have to run 3 services just to get everybody through, and they're jam-packed. And so those are really two very, very different scenarios. I have really big, my downtown sanctuary is huge, it holds 750 people, and they worship maybe 120 a Sunday. So they can very easily socially distance. And so those are the kinds of considerations that really need to be in play. So there isn't a one size fits all answer. And I know that's not a shock to any of you. I think the real answer is, like I said, I looked up your stats. You are actually in pretty good shape in terms of vaccination. You're in better shape than I am, to be quite honest. So that when a session comes to me and says, but everybody's vaccinated, I'm like, yeah, statistically only 50% of you are vaccinated. If your population is all over 80, there's a better chance that you're all fully vaccinated. But there's also a chance that, again, with breakthrough coming at a highly susceptible population, one who have underlying medical conditions, if you're all 80 degrees and there's going to be some other things, I'd still err on the side of caution. So I have told the churches here, it's session's decision. If I were queen, which I am decidedly not, I would ensure that everybody stayed masked for the duration of the service. If you're going to sing with masks on. I really still don't like the idea of choirs, just because there's so much more rehearsal time, and a really good choir has to stay fairly close to be able to hear the other parts. So that's not a great place to be, but if you're going to do it, you can do it with a singer's mask, that's fine. Fellowship, we're all getting back to cold weather and fellowship indoors. And fellowship is where the masks come off and the community starts, and that's where people come together. And so again, you're never going to eliminate all risks. All you can do is eliminate the risks you can. You're never going to get it risk-free. So if you're going to do fellowship, some churches are doing individually wrapped things. I suggested donut holes, but they thought that might be too many things to wrap individually. So they went to full donuts. If you're going to do a buffet, as much as you can separate people, that kind of thing. And people have been, I think, fairly reasonable about it. Church, the length of the service, there's an interesting question, because I think most churches, when we went virtual, sized it down to about 30, maybe 40 minutes. And I'm now seeing people who are going back to in-person get squirmy at about 30 to 40 minutes. We're not used to sitting still for a worship service for an hour anymore. So it's sort of interesting. But again, I think it's what people are comfortable with and what session will mandate.
What about youth and youth activities and fellowship events for youth?
Yeah, that's a really good question too. High school, is the same as an adult. If they're vaccinated, and if they can be outside, if they can do something masked, they will be safer. That's not always easy. I understand that, but I think that's the best advice I can give. That's probably the same for little ones who are not yet vaccinated. We've been asking, actually, if you've got a Sunday school that is still meeting, then you really do need to be taking some precautions. You need to make sure those kids are masked, that they are distanced as much as they can, that things are sanitized, that the touch factor isn't so much as a way of spreading it, but if they're touching anybody or anything that's infected and they touch themselves, which kids tend to do, they touch their eyes, they will get an infection that way, or they can get an infection that way. And we've actually also said that probably should be a truncated time. So if you've got an hour service, if you're going to do a Sunday school lesson, I would keep that to no more than 15 minutes or so, which puts a lot back on the parents, I understand. There's one in the chat.
Chat talking about the liability of the companies producing the vaccines, and can they be sued or not? And if so, what about other vaccines?
Yeah, it's a really good question. So I will say first, I'll answer the last question first. Smallpox, polio, those vaccines were around largely before litigation was such a big thing in our society. So I'm not sure that's ever been tested. So the answer really is, you can absolutely litigate anything, but even with medicines, unless there is a large number of people who have that same side effect, and you're showing that it was a side effect that was not detected in the clinical trials, so it's unexpected, and it's serious, and it wasn't reported to FDA where FDA was aware of it, that suit might prevail. But that's usually one of those huge class action suits that you hear, sort of like the cervical cancer that J&J just did with baby powder. That's the kind of suit that you get, but it has to be that kind of thud weight. An individual that says, I had a breakout of hives because of your vaccine, that suit will not go anywhere. And I've heard, so I have a lot of conversations like this. I have a lot of friends actually who are not anti-vaxxers, but are scared of it. And so the stories start to come out that, well, my husband got atrial fibrillation from the vaccine. Well, probably not. Your husband's 200 pounds overweight and has diabetes. And so the causality is the key to any litigation. If you can absolutely prove that there was no other factor that could have caused that side effect, then you have something that could become a class action suit, but still is unlikely to prevail in a court of law. I will say that the difficulty in proving causality of any one side effect, or any death for that matter, to a specific drug is really difficult to do, because so many people who have a side effect have other medications, have other medical conditions. It's just an almost impossible thing to do. And it's really difficult when you're in a clinical trial to even delineate that for a safety review for FDA. It takes a lot of forensics to get there.
And my understanding is that, many of the anti-vaxxers do not trust the pharmaceutical companies in the rush to get the jackpot, that they may have cut corners on trials or things. And can you give us some understanding of what actually goes on?
Yeah, I certainly can. So there were no corners cut because, again, we are in an epidemic crisis. So let me go back. There are 3 phases of clinical trials. There's phase 1, which is a couple of people so that they can sort out dose and look at safety. Then once that passes through, they go to phase 2, which is a larger number of people with a specific dose, where they look at a broader array of efficacy and safety to get to a final dose. And then phase 3 is literally tens to hundreds of thousands of people, where you're really looking at the efficacy, any side effect profile that comes up and compiling that, and then looking at disease progression in this case. So in the case of the mRNA vaccines, because we've had 30 years of previous experience with that platform, with the mRNA approach, where we have 30 years of safety data, we already knew that the platform itself was safe. The only thing that had to be done to that platform then was to take the protein mRNA and put it in the platform. So we took the protein from the spike of the COVID and put it on the platform, and that becomes the vaccine. The virus, the original virus, had its complete genome translated January 11th of 2020. So within 3 weeks of it showing up in the US, we knew genetically exactly what that COVID was. So we took some of the protein. That's what's the slight difference between Pfizer and Moderna. They took slightly different parts of the protein, and they're both mRNA platforms. Because we had so much safety data on it, they combined phases 1 and 2. So they looked at a number of doses in a larger group of people to see what was the most efficacious, if they could find efficacy. Remember, the original mRNA vaccines that we tested for Zika and Ebola and HIV, they were safe. They never worked, was the problem. They were never released because they were not efficacious. This time, efficacy showed itself immediately. We knew what the dose was, and we knew what the safety platform was. So they went into large-scale phase 3 trials, both Pfizer and Moderna. Now, to get approval for a drug or a vaccine, you have to have 2 identical trials, both showing positive and safe results. That's the baseline. Both Pfizer and Moderna had trials of 40,000 patients each. They were meticulous about including a diverse population. So BIPOC were very well represented in these clinical trials. They also incorporated a subset of pregnant women, which is unusual in these trials because you're really looking at long-term effects. But they knew that this was going to be a population at risk. And so that large-scale clinical trial set is what FDA reviewed for first emergency use authorization, and then final approval. And again, that final approval is just a longer term safety data set for that specific vaccine. So there was no corner cut in the clinical trials. It was really, really well done. It was exceptionally well researched, in the sense that every patient was followed up several times after they got the vaccine to make sure that anything that emerged was caught. And so the accountability of these pharmaceutical companies, but also the investigators that were involved in it, was really exquisite. And the other thing, and I've said this from the beginning as well, because of the crisis nature of what we've been facing globally with COVID, the scientific and the medical community and the pharmaceutical companies as well normally keep the data very close to the vest, so that when they publish, it is their data. Nothing about COVID research has been privatized. It's all been open source. So everybody knew immediately, who had access to these things, exactly what the protocols looked like for the Pfizer study, for the Moderna study, for the J&J study, who was being included, what was coming out in the data. And then as they started to release the data, first for sort of press release kind of data, yes, this is the level of efficacy we've seen. And then when they released it to the scientific community, you could really go through it side effect by side effect by side effect to see what was common. So, fever, fatigue, the kinds of things that you get with a flu vaccine are common with the COVID vaccines. And then things like heart attack were extremely rare. And again, that causality comes into it. So these are exquisitely well tested. They are well reviewed. And they continue to be well reviewed. So even now, the patients who were in the original clinical trials are still being followed up to see what has emerged.
Whiplash time, moving from the science to the ministry. I've received kind of a private request for a question about churches that really are trying to be conscientious. They may be meeting outside or not meeting at all. What is advisable for them about how they can, when is it going to be, what benchmarks should they be using about moving indoors, especially if they can't really spread out in their worship?
Yeah, it's a really good question. We've looked at things like infectivity rates, and I urge you to go back to covidactnow.org as a database. That's a good one. CDC has also a county by county database. The counties have pretty much stopped keeping their own data. The states do. So pick one data source and stick with it. I think if you look at hospitalization rates going down, death rates going down, ICU ventilators, that rate going down, where the hospitals are beginning to breathe again. If the infectivity rate, is going down, so we're getting to an R, which is that replicative value. How many people are you infecting if you're infectious? If it's less than 1, that's a really good benchmark to go back, particularly for those churches. And I've got several who have not gone back in 19 months. They tend to be BIPOC populations that are at extreme risk. We've known that for a while. Or the pastor is at extreme risk, and the population is just being really uber cautious. What they've said is that if we go back before Advent, and I think that's probably unlikely the way that they're talking about it, we will go back fully masked, and we will find a way to distance, even if we have to find somewhere else to worship. And so I've got 2 churches that are at that place right now. Most of my churches are following state and CDC guidance that says, if you're vaccinated, you're not required to be a mask, but we recommend it. And if you're unvaccinated, we trust you to wear a mask. That's pretty much where they are. Not every church is able to distance as much as they used to be able to, because more people are coming back. That's good news. But they are being very cautious about fellowship hour and sort of truncating anything after the service itself.
Yeah. Our Presbytery Council has issued advice last November that there still is in effect, that if you look at the risk threat, maps that you see on COVID Act Now or CDC, and if it has been yellow or green for 7 days,
yes,
then okay. But if it goes to orange or red or magenta, my gosh,
yes,
then you should not be meeting in person.
And that's, that's really great. I think the only thing I would add to that is if you've had any exposure of any kind, just because this is so highly infectious, that you probably should close down for a Sunday at least. and let everybody who might have been infected know. And I know I've had one church just this week that, somebody who wasn't vaccinated came into the office without a mask. And so they had to shut nobody caught it, thank God, but they had to shut the church down for a week.
Yeah.
So
the information and the guidance from the council can be found on our Presbytery website and from our council, and Stacy will put the actual link up there, I'm sure.
Yeah.
Good.
Here are two places that you can get county by county information that are really quite good.
Right. So, and those other links are also in the Presbytery advice that Stacy's just put the link up. Before we open it up to questions from the participants here, what words of hope do you have for the church?
For the church?
Other than the hope that we live in and Christ is risen. That's our hope.
That's right. No, I mean, I think, my prayer is that we don't have a variant that emerges with a large unvaccinated population that puts us back to ground zero, that really is the vaccines that we have are not able to handle. The nimbleness of the pharmaceutical company for this has been stunning. And so I think those challenges can be met. I think this will end at some point as soon as we can vaccinate the 5 to 11. And there are studies going on as young as 6 months. When we can start to vaccinate at that age, then you start to get to something that does look like that herd immunity. That was a big conversation last year. Herd immunity for something that is this infectious and this prevalent is at least about 80 to 90%. It's much more than the usual 70%. But we are starting to edge there. If people keep up with it, if they keep up with good behavior, we will come through this. And I do believe we will come through it. I think it will be into 2022 before we do. I really do. Particularly when you look at the fact that some international travel is still opening up. It opens and it closes. And less than 2% of people in developing countries are getting this vaccine. So we still have a very, very long way to go globally. But I think locally, there will be a jumping off point for this where it will exist at a low level and people will get used to the idea that this is like the flu, you should get vaccinated for it on a periodic basis. I think for the church, this is maybe where I get on my sort of preacher's soapbox. I have seen churches begin to wrestle with the question that should be wrestled with in a liminal space like that. And that is, what is the core of who we are as Christians? What is the core of what we do in a church? And it's not our building, and it's not all those cute little mission things that we did. The core of who we are is to worship and glorify God. And they've gone back to some of that foundational piece in a really beautiful way. It doesn't mean that they won't go back to mission when they can get out again, but they've hunkered down in a worshipful way that I think is good. I think they've also realized, because the building is not the critical thing here, that you can't be Christian if you're only Christian inside the walls, that you've got to get out and do what we've been asked to do, which is love God, love people, and make disciples. And so I have seen some really beautiful things emerge from the church from this.
Wonderful. Thank you so much. Just really brilliant presentation, full of detail and expertise that we really do appreciate. At this time, I'm going to take you off the spotlight. We'll do that first.
That's good.
And remove spotlight. There we go. And so people can return to the gallery view and you can see one another. If you have a question, we would invite you to use the raise hand function under the reactions button on your control bar. Or if you can't access that, just kind of crazily wave and we'll see what we can do to find you. Or if you have a question you'd just like simply to put in the chat, and we can do that and try and incorporate that as we find them. So once again, thank you. And what questions do you have?
Thoughts about letting outside groups continue to have meetings within the church? It's a really good question.
Okay, Megan has a question.
Hi, Lisa.
Hi, Megan.
Hi, thank you so much for sharing all of this. I really appreciate it. So I had to leave the room. I'm a music director, and ironically, I left the room shortly just as you were talking about choirs and things like that. So, I mean, I was taking notes on all the good news you were talking about at the beginning about the efficacy and like all of that of the vaccination status. And we have currently, we require all of our music people to be vaccinated, whether you're in the choir, the vocal choirs, the bell program, anything.
Mhm.
So could you please just kind of quickly, sorry to have her reiterate, but talk about how we could, how we can be together safely, or the things that you were talking about, because everything in the beginning sounded like really great news and I was really excited about it. And I want to know how that relates to us being able to rehearse together.
Yeah, it's fair. And if I can dig it out, I will send you a video that was the product of a couple of college music directors doing some studies with their own people, primarily on singing. And basically what they said was, first of all, there are masks that have better air volume for singers. So not the fabric masks that you end up breathing in every time you take a deep breath. And if they seal well, that's good. That's the important thing. They have to be able to give the singers air, and they have to be able to seal well enough that you're not expelling air. It's not possible to completely eliminate that, but as much as you can. This study basically said, if you can rehearse with people who are practiced and talented enough to be able to listen at a distance, that's the best you can do. And they were recommending rehearsal for a trained singer at least 6 to 8 feet. What we've said, and I've got other videos on this too, a trained singer without a mask is going to project at least 24 feet. And so particularly as we're getting into drier heated air, because the droplet particles become so much smaller in that dry heated air, it actually travels farther. It's literally a simple physics. If you're in a hot, humid environment where the droplets are bigger, they're just going to fall to the ground faster. But in a dry heated air, they're going to travel faster. So if you have a choir or a bell choir, because there's significant rehearsal time, and because most singers who aren't trained have to hear the parts around them, they have to stay close. So my advice is separate everybody at least by 6 to 8 feet when you're practicing, and masked at all times.
Great, thank you. Jim Lyles had a question. Jim, please unmute and share your question.
Yeah, I guess I have heard something about a combination shot that does both the flu and the booster. Do you know if that is actually out, and is there any reason why that would be a problem? It seems to me that's the way to go if it's available.
I haven't seen that. And as far as I know, that's not been approved by FDA. It might be in other countries, but it's absolutely, and I've checked this on a couple of different places. I've checked it with one of my CDC buddies. You can get literally one in at the same time, one in each arm. There's no reason why you can't do that. So the flu season this year is being predicted to be bad for a number of reasons. And there's an organization called Fan Flu that actually tracks it out of Southeast Asia every year to see how it goes around the world. And so I would highly, highly, highly recommend a flu shot this year, and would recommend the COVID booster if you can get it. Absolutely.
Thank you. Mary Ann Parker has a question. Please unmute yourself.
Hi, Lisa.
Hi, Mary Ann.
I find this very interesting and very enlightening today. I appreciate.
You went into mute, Mary Ann.
I do have a question about the booster.
Mhm.
2 of my family members they've had the Pfizer 1 and 2 in the springtime, and then they developed COVID in August. When is a good time for them to get a booster shot then?
It's a really good question. First of all, I mean, they really should check with their doctor. But originally, before the boosters came out, the advice was wait 90 days after you are clear of COVID before you got your first shot of the vaccination. I don't know, but I will go look it up to see if that is still a recommendation for the booster. But that was the original recommendation, was wait 90 days, because you don't want competing antibodies, essentially.
Right. Okay. All right. Thank you.
You're welcome. And Dan, Bonnie Marsh has one question on chat. It says
Okay.
thoughts about letting outside groups continue to have meetings within the church. I think the answer is probably the same as original. If session has a set criteria of what needs to be true to worship, that same criteria needs to be true for any outside groups that are meeting in your church. So if you're requiring masks of your congregants, you would require masks of the Boy Scouts. And, you know, again, I would keep them from running all over the building. You might want to do that with Boy Scouts anyway, but I would keep them in a single room as much as you can so you know where they've been and not let them go elsewhere in the church where they might be encountering someone else. But basically the same rules would apply.
Very good. We've been joined by John Baker. John,
saw
member
that.
of our Presbytery, who is a CRE at Rosebush, but also Director of Labs at Sparrow Health Systems and part of the public information campaign on COVID at Hillsdale Hospital. Welcome, John. I don't know if you can join us or not. There you are.
Sort of. I apologize for being kind of on and off. I am simultaneously on a WebEx call for our hospital incident command right now. So, but I extend a special thanks to Lisa. This has been a very valuable presentation, and thanks for doing this for us, and Dan for putting this together.
John, maybe you can tell us a little bit what it looks like on the ground, you know, in terms of the hospital situation.
Well, things kind of leveled off a little bit in past weeks, but right now, what we're meeting and working on today is the fact we are running out of beds. We are running out of capacity to deliver monoclonal antibodies. We're keeping up. You know, that's a very important strategy for us as a health system. But we're seeing lots of people from other health systems come to us for that. So we're trying to find more and more locations where we're able to do that, and we're just moving patients around everywhere we can. So we're at the point right now. You know, the numbers aren't as big as they were in the large spike in the pandemic here in Michigan, but they're certainly headed that direction. And we're already starting to take care of patients in non-traditional spaces and looking at where we can expand. One of the challenges this time around, of course, is that everything else is pretty much still open. So, you know, before when we pulled, you know, healthcare professionals from all kinds of other places that were not open, that, you know, that helped us to be able to care for all these patients. So, and this is a story across the country. Staffing is just really, really challenging. So, but we're not beyond our capacity right now, but we're getting there.
All right, thank you, John. I'm going to give another call for questions if people have them. You can put it in the chat, raise your hand, or just wave. Nobody is rushing to ask a question at this point. So I just want to say thank you to Lisa. Let's all show our appreciation to her. You are really a gift to the church with your expertise and your ability to communicate it effectively. And we appreciate your ministry in this regard, but also your ministry in Cincinnati Presbytery.
Well, thank you. You guys be safe. If you've got other questions, send them to Dan or send them on to me, and I'll see if I can go find the answers. But be blessed. It will be well.
Let me close our time together in prayer.
There's a question in the chat for John.
Oh, we have a chat. We have a question. John, is the wave of COVID worse for staffing than the first wave? Can you answer that? I think John may have had to go to a different. Oh, there he is. He's coming.
Hey, sorry. Yeah, could you repeat the question? I was distracted.
Yes, we have a question in chat for you that says, "Is the wave of COVID worse for staffing than the first wave?"
It is primarily because this is happening much more simultaneously across the nation rather than moving in waves. And as I said, the places that we were able to pull staffing from before, they're just not available. We had a lot of physician offices closed. We could pull nurses from there. We were pulling athletic trainers out of the field, and we're simultaneously right now engaged in still fairly massive vaccination campaigns. So there's just not enough available staff to flex as there was before. So it's more challenging this time around than the first time.
What is it like for the care providers mentally, physically, psychologically, emotionally? How does it compare?
They're quite weary on average, as is as is leadership. We're talking to hospitals around the country says, well, 5 nurses left today, plus three of our administrators just decided to hang it up. So I mean, we're doing better than that. It's not as dire here, but we've certainly seen our wave of people who just decided they're not going to do this anymore. It's been going on for quite a long time. So I do want to say that the picture here is a little bit more upbeat. And at the same time, we're struggling with all kinds of very strange supply chain shortages, which just helps to complicate everything else. So, so I don't know. We're doing okay. We're weathering the storm.
I'll point out that pastors are having a similar experience of weariness. So
yeah, I could go to the hospital and get away from it for a little while.
yeah, something about frying pan and fire. I'm not sure. Anyway, thank you for your answer, John.
Thank you.
I'll give another chance for questions before we close in prayer. Going once, going twice, let us pray. Once again, dear God, we give you thanks for Lisa and for the expertise that she's been able to share with us. We thank you for her ministry in Cincinnati Presbytery and to our whole denomination, especially in regard to our pandemic. We pray for our pastors and congregations growing weary of guidelines and restrictions. Help us to continue to be faithful in our response and our care for one another. We pray also for care providers who have grown so weary through this pandemic, some of whom have even given their lives in treating others. And we do ask that you would sustain them, know that we care for them, and to help us to show our appreciation to them at every opportunity. And now, O God, as we leave this meeting, may we go with your blessing, knowing that as your people here on earth, you call us to show your love, your compassion, especially to all, but especially to the least of our brothers and sisters. So bless us as we go. Keep us faithful, keep us healthy, keep us vibrant in faith. For we ask this in Christ's name. Amen.
And
All right, thanks to everyone. I'm going to be closing the meeting in about 5 seconds. So once again, thanks to Lisa and John and to all who had questions and participated.
take